Good afternoon, everybody, and welcome to today's CME, courtesy of the Arakan University Hospital CME office. Once again, I have to thank the team there, Shelmith and team, for making sure that our CMEs run every Thursday, and we do have some educational activities which improve our patient care. My name's Dr. Mzee Ngunga. I'm a cardiologist working at the Arakan University Hospital, Department of Medicine. I work in the section of cardiology, and today I'm happy to be moderating today's session. Today's session is going to be on a very common topic, which is hypertension. And in particular, we are going to be talking about resistant hypertension. So today's topic is going to be presented by one of my colleagues, Dr. Etienne Amendezo. Dr. Etienne Amendezo is a cardiologist, interventional cardiologist, who is part of our cardiology fellowship program. And I'm really glad he's here to talk to us about resistant hypertension and what is in the cards for the patients with resistant hypertension. I'm really happy we've been seeing much more research and work coming in terms of resistant hypertension. And I'm sure Dr. Etienne's clinic and Etienne's work will come a long way in helping us understand more about this condition. I'm really delighted to talk about hypertension this month because the month of May is particularly dedicated to what we call the May measurement month. And even the clinicians who take care of patients every day sometimes forget
People are usually so busy.
for these conditions. So please, if you walk around our hospital, you will see a tent outside there. Please pay a visit that tent, just have a seat, relax, and someone will tell you your blood pressure is normal or abnormal. If by any chance your blood pressure is too high, then we'll attend to you in any of our clinics. And indeed, if it's resistant, then Dr. Etienne probably has some solutions for you. Another thing which I'm delighted to talk about is something we call the resistant hypertension clinic, which is one of our trademark clinics in the hospital, particularly dedicated to those people who have resistant hypertension, because we do have some people who physicians struggle to control their pressure. And we believe we have a solution for you. So if you have any patients who have resistant hypertension, please send them to our clinic. Dr. Etienne will probably tell us in this presentation what the clinic offers. It runs on Thursdays and Fridays every week. One of the things I have to report also in this today's session is that we are now offering renal renovation therapy as part of our registry, because we are accredited to conduct this procedure in our hospital. And all the patients we conduct this procedure go into a registry for the purpose of follow-up as part of a large worldwide registry to see the efficacy of this treatment in a select number of patients who have resistant hypertension. This activity is CPD accredited, so all of you will participate. You will get a chance to get CPD points, courtesy of our CPD office. At the end of the session, I am going to moderate the Q&A. And I think since we have enough participants now, we have more than 100 people online, Dr. Etienne. I am happy to get you in the audience to tell us indeed what you have in store for resistant hypertension, which is a common problem that we see in our clinic. So without much ado, Dr. Etienne, the air is yours. Please, we are listening. Please write all your questions in the chat box next to you. And I am sure we shall have answers for you in the next 45 minutes or so. So Dr. Etienne, please go ahead.
Hi there. Can you hear me?
Sure, Etienne, go ahead.
All right. Well, thanks. Thanks, Dr. Ngunga. Really pleasure to be with you and to talk about resistant hypertension. What I'm gonna do is to go through, what is new in hypertension in general, and then to tackle the subject of resistant hypertension and how the approach to management is important for all of us to understand in this era. Hello? Can you hear me?
Yes, go ahead. Someone was just unmuted, but
Oh,
go ahead.
correct. Good. So, as we know, hypertension is a global health crisis. It's the leading global modifiable cause of heart attack, stroke, and mortality. The incidence is also worryingly high. The average prevalence is 1 in 3 adults are hypertensive globally, and the control rates are really low. About 60% of people who are treated for hypertension are not well controlled. The ESC published guidelines for management of elevated blood pressure and hypertension in December 2024. And I'll use this article to sort of go through some of the key aspects of recommendation from the ESC in terms of management of hypertension. So number one, there's a new classification for elevated blood pressure. This is something between normal and hypertension. Hypertension starts at 140/90 millimeter of mercury, and normal is less than 120. If your blood pressure is between 120 to 139 over 70 to 89, then you don't have a normal blood pressure, you have elevated blood pressure. And many people will actually find themselves in this category. Number two, there are revised treatment targets for hypertension. The target should be 120 to 129 millimeter of mercury over 80 of diastolic if the blood pressure medicines are well tolerated. Number three, whether you're old or young, the target treatment targets remain the same, provided the patient is not frail. Number four, there's an emphasis on out-of-office blood pressure measurements for reasons that we all know that there are so many cases of white coat hypertension that just makes the picture a bit difficult to interpret. White coat hypertension, again, is not a benign condition, but it's important to put emphasis on out-of-office blood pressure measurements. Number five, it's important to screen every hypertensive patient for secondary causes, and you'll be surprised that the drugs the patient take for whatever other reason actually contribute a lot to development and sustaining of hypertension. Number six, patients with apparent resistant hypertension, something that I'm going to define in the next few slides, should be seen in dedicated hypertension clinics and should be considered for an interventional approach to manage this type of patients in renal denervation therapy. Now, let me just go back a bit on frailty and age. This guy going to be different from that old mama. And if you're dealing with an old person, and old is widely defined, you should probably base on biological age rather than chronological age, and I'm sure all of you know the difference. But also, if you're dealing with a person who is frail, moderate to severe frailty, or who have comorbidities with reduced life expectancy, or those that have suffered orthostatic hypotension in the past, then the treatment targets should be different. And the recommended treatment target for this type of people is between 140 to 150 systolic. Everyone else should rather be treated to target with a target of 120 to 129. But where do these new blood pressure targets come from? They actually come from research. And this trial, the SPRINT trial, which was published about 10 years ago, showed clearly that an intensive blood pressure treatment strategy is better than the standard treatment target by the fact that it reduces the events of the of conditions such as stroke, heart failure, MI, and cardiovascular mortality, which were the variables of the composite of the primary outcome. And that clearly shows that intensive treatment strategy resulted in significant lower events of this primary outcome compared to a standard treatment that was targeting a blood pressure of 140 millimeter of mercury instead of 120, which was the intensive treatment strategy. Now, very recently in a diabetic population, the same or similar kind of study looked at the same problem. And it did confirm that people, when they have or when they're subject to intensive treatment, they actually do better in terms of preventing stroke, heart failure hospitalization, myocardial infarction, and indeed cardiovascular mortality over a period of about 5 years. As these two studies and many others show that treatment to target of 120 to 125 thereabouts is better than a treatment to target of 140 to 150, which majority of clinicians actually still do. And indeed, the other thing is the actual impact of blood pressure control. You won't be surprised to see that over 1 million adults that were included in this study, it was shown that slight reduction in the mean office systolic blood pressure of 2 millimeter of mercury resulted in about 7 to 10% reduction in risk of cardiovascular mortality. And this, again, confirms that reducing blood pressure remains the single largest reversible risk to lower cardiovascular mortality. And whatever way one can do it, whether through lifestyle, medication, or interventional treatment, are going to be beneficial to the patient long term. But indeed, there are differences in perceptions. What we see and what we feel as clinicians, there's also what the patient sees. And most patients with blood pressure problems suffer the feeling that medication is just too many and they can't do it. And so that explains the rate of non-adherence and the rate of dropping to take medications. This study, for instance, and it's an old study, but it does show something we still see in the clinics, that half of the patients end up stopping their blood pressure medication within 1 year after the first prescription. And there are many reasons to this, but there are three major key to this kind of situation. Number one is patient's non-adherence. Number two is the physician inertia. Number three is the complexity of the regimens that we do prescribe to patients. If you see a patient with cancer, hypertension, diabetes, atrial fibrillation, and so forth, who is on 10 medications, it's going to be difficult to sort of predict that this patient will sustainably remain on these all medications for a long period of time. And these are barriers to medication adherence, which are multidimensional. I really don't want to go too much into the details, but for hypertension particularly, the lack of symptoms in majority of patients with hypertension is a major contributor to actually medication adherence. But there are many other reasons, including medication side effects, like I said, complex drug regimen kind of situation. And again, poor understanding of the illness itself and communication barriers in some of the clinics. The reasons for physician inertia are also many, and most physicians, according to report fear of the side effect profile to the patient. Some, fear is based on the fact that physician would think that there are dangerous side effects such as inducing hyperkalemia, then that will lead to, sudden cardiac death, or inducing renal failure, or fearing orthostatic hypotension that is induced by medications, and things like erectile dysfunction, which is quite common in people with hypertension. All in all, I think the most important thing is to get the patient involved in the conversation and report potential side effects that may occur in a patient who presents to you and who needs to be prescribed antihypertensive medication. But let me now transition from hypertension in general as a disease process to what we call resistant hypertension. I'll go through a case presentation to just help us transition. So I recently saw a 66 years old male obese patient who is an ex-smoker. He's been hypertensive for 7 years and he has obstructive sleep apnea. He's seen a pulmonologist. He's been put on a CPAP machine. He also has paroxysmal atrial fibrillation. He's otherwise asymptomatic. His office blood pressure is 155 over 100 millimeter of mercury. And these are mean of 3 readings using an automated device, appropriate cuff size, both arms in a sitting position after 5 minutes of wait. His heart rate is 72 beats per minute. This is a list of medication he's taking. He's basically taking valsartan, amlodipine, hydrocortisone at pretty good doses, but he's also taking bisoprolol, so 4 antihypertensive medications plus apixaban for stroke prevention. His physical examination, other than him being obese, is unremarkable. And his ECG shows LVH and a slow atrial fibrillation. So his labs, you can see his eGFR is slightly reduced. His potassium is 3.8. He has a proteinuria, and he has a prediabetes A1C of 6.4%. So let's analyze this a little bit further. What do you think of this patient's blood pressure readings in the office? They are high, right? But you have to be cautious because this guy has atrial fibrillation, and the use of automated blood pressure machines can be a bit tricky. You have to realize that if the rhythm is not regular, then the readings that you get on the blood pressure may be different. It may be high, it may be low. So you have to interpret it cautiously. The other thing is that whether this patient has target organ damage, and you agree with me that yes, he does, because he has kidney dysfunction. He also has LVH on the ECG, which means he probably has significant left ventricular hypertrophy. Does this patient have resistant hypertension? Probably yes, and we'll go through the definition and clarify this. But one important aspect is to look at the accuracy of office blood pressure to diagnose resistant hypertension. In fact, you really can't base on office blood pressure measurement because it's not enough. And like I said, there are situations such as atrial fibrillation, but it's also an issue with white coat hypertension that you have to put into consideration. What you need to do is actually to use an ambulatory blood pressure monitor. I'm not sure how many clinicians in Aga Khan or across the board use ambulatory blood pressure monitor for monitoring, but also for treatment, assessment, and evaluation in patients with hypertension. And so in this particular case, his mean 24-hour systolic blood pressure was 142 and a mean diastolic of 89. His awake daytime blood pressure was 149 and asleep was 135. All these measurements, as you can see from this table from the ESC that gives the actual definitions of what we should consider as hypertension or uncontrolled hypertension, all these measurements for this patient fall into the uncontrolled category, which means that it does indeed confirm that he's got severe hypertension that is not controlled. So in summary, 66 years old male patient has treatment-resistant hypertension that is confirmed with ABPM. He's on 4 medications, including an ARB, CCB, beta blocker, and a thiazide diuretic. He's said that he takes his medications religiously, which sort of confirms adherence. And that can be a bit difficult.
What are they?
We kind of base on what the patient tells us. There's no way to measure drug levels, particularly in this part of the world. Even if you are to do, it's usually based on qualitative measurements, which is not as accurate as if we are to do quantitative measurements of drug levels. But all in all, we base on the patient history and what he tells us. Regardless, though, even if this patient had a good blood pressure measurement of less than 130/80, being on 4 medications classifies him into the resistant hypertension group. But he also has OSCE, he's on CPAP, he has paroxysmal atrial fibrillation, he's appropriately anticoagulated. And so how do you manage this type of situation? And so that takes me to discuss now resistant hypertension, which is a very prevalent condition. The rate is about 15 to 20% of all hypertensive patients, about 1 in 5. And we do differentiate 2 types. This is what we call true treatment-resistant hypertension and pseudo-resistant hypertension. True treatment-resistant hypertension are those people that take their medications. We've ruled out secondary causes of hypertension, and they still have the blood pressure above target of 140/90. These patients are at significantly higher risk of adverse cardiovascular events, and they require high quality and consistent care to mitigate adverse outcomes. And this is just a definition according to the guidelines. In the definition, you clearly said that you have to confirm the blood pressure control with an ABPM. We also have to be able to rule out causes of pseudo-resistant hypertension, including poor medication adherence, and to rule out secondary causes. I'll give you a story here. So recently, we actually had a patient presenting with severe hypertension and epic success. This patient had been on 4 medications, or at least she claimed that she was on 4 medications for several months, and her blood pressure was not well controlled. In fact, I was contemplating to give her a renal denervation treatment. And then she unfortunately presented with a severe epic success that could not be controlled with standard means. And we had to admit her to the hospital. While in the hospital, she was given the same treatment she was getting as an outpatient. And guess what? Her blood pressure improved from 190 to over 100 to about 120 over 75. And when she was discharged from the hospital, she actually had a presyncope because she became hypotensive, taking all the 4 medications that she was taking. Just to confirm and to an example that poor adherence can actually trick us that this patient has treatment-resistant hypertension while it's just pseudo-resistant hypertension because the adherence is not there. There are different causes of pseudo-resistance, and the number one cause in probably every society is non-adherence, but also inadequate treatment doses. And some generics may not have the actual principle and the same amount of actual principle, although this is really difficult to judge. But improper blood pressure measurement techniques and white coat hypertension, like we said, and again, secondary causes or a combination of factors could be reasons for pseudo-resistant hypertension. All in all, whenever you see a patient for the first time, if they have new onset hypertension or if they have uncontrolled hypertension, there are certain clues that would indicate that you need to screen this patient for secondary hypertension. And these include if the blood pressure is not controlled with medications that we've prescribed, or if they have abrupt onset of hypertension, or if they have exacerbation of previously controlled hypertension, or if they have disproportionately high target organ damage for the degree of hypertension that you've seen or that you've been seeing, whether using home blood pressure monitor or office blood pressure monitor. If they have malignant hypertension or onset of diastolic hypertension, particularly in older people, or if they have excessive hypokalemia or unprovoked hypokalemia, then all these situations are clues that you need to rule out secondary causes of hypertension. And if they do screen positive for all this, then you should refer this patient to a clinician that have expertise managing this type of situations. There are also reversible causes of secondary hypertension, and they include medications, obesity, sleep apnea, primary aldosteronism, renal artery stenosis, coarctation, and so on and so forth. And all this, if you see them, then they have to be addressed because they are generally easy to address, actually. The most common medications are going to include NSAIDs, decongestants, and oral contraceptive pills. And there are the list is really long of these medications. You just have to go through the list of medication the patient takes. So now, in patients with obstructive sleep apnea, which is indeed an independent risk factor for cardiovascular events, including stroke, MI, and heart failure and mortality, the prevalence of a combination of OSA and hypertension is pretty high, particularly in those that have drug-resistant hypertension. And the reason is just beyond the combination itself. It's also the fact that there is an increased sympathetic overactivation that plays a pivotal role in both disease processes. And the treatment, as we know, for OSA is going to be CPAP, and it benefits more people who have resistant hypertension. And it has shown that CPAP can actually help to reduce blood pressure by 7 to 10 millimeters of mercury, which is pretty good if you look at it long term. However, CPAP cannot be used to as a mean to achieve discontinuation of antihypertensive treatment. You've probably seen this, but it's bad practice. How about primary hyperaldosteronism? It is important to screen for primary aldosteronism in all adults who are confirmed to have hypertension. The reason for this is that the studies have actually shown that it's a much commoner problem than previously thought. And the way you do it is you're going to get an aldosterone and renin ratio. And if this is high, then you proceed with saline infusion tests, which should, if this primary hyperaldosteronism, should fail to suppress aldosterone. If aldosterone cannot be suppressed, then you have to obtain imaging, usually a CT scan of the adrenal glands. And if the CT scan shows that is a mass or hyperplasia or dilatation of the gland, then you have to confirm if that mass, that adenoma that you're seeing, is the one that's creating aldosterone. And you do that by doing adrenovenous sampling, which is a procedure that we can do. And if you do see there is bilateral hyperplasia, or if the person is an elderly person who cannot otherwise undergo surgery, then generally aldosterone antagonists such as spironolactone is going to be the treatment of choice. But if there is a unilateral adenoma or hyperplasia in a relatively young person, then you can send them to surgery for adrenalectomy or adenectomy, which would indeed help to reduce the rate of hypertension and hopefully cure both hypertension and primary aldosteronism. Renal artery stenosis is also another cause of hypertension. It's much rarer than primary aldosteronism, but it does present as hypertension that is generally difficult to control, that is associated with kidney dysfunction, particularly when the patient takes OSCE inhibitors or ARBs. And you have to have, or some patients will develop chest pain syndromes, pulmonary edema, or headaches. And if they do, then you have to think of renal artery stenosis, particularly in the young patient. Renal bruit is present in only 40% of these patients on clinical examinations, so it's not necessarily a reliable way to diagnose renal artery stenosis. But Doppler ultrasound, which is something that we do in radiology here, is most common method of choice of diagnosing renal artery stenosis, not as accurate as a CT scan or MR angiography. And the gold standard will be invasive angiography that will help you to delineate there is a pressure gradient between the proximal part of the lesion where there is stenosis and the distal part of it. And if there's evidence of renal artery stenosis, then stenting can be done if there's severe, difficult to control hypertension, or if there's significantly reducing renal function, or if there's intolerance to OSCE inhibitors or ARBs, or if there's frequent or recurrent flash pulmonary edema. Now, let me just discuss true treatment-resistant hypertension. The management of it is actually simpler than what people may imagine. The guidelines are clear. If you have a patient with resistant hypertension defined as blood pressure 140/90, despite 3 or more blood pressure lowering medications at maximally tolerated doses, including a diuretic, then number one step should be to refer this patient to a hypertension center where treatment will be optimized, but also where exclusion of secondary causes of hypertension and pseudo-resistant hypertension will be made. At the clinic, at the referral center, what they're going to do is reinforce lifestyle measures and discuss with the patient, make a choice between adding more medications or going through the process of doing an interventional treatment in renal denervation. And all in all, what you want to achieve is a better blood pressure control with systolic less than 140/90 diastolic. So let me talk a little bit about renal denervation. Some have thought about it as an alternative to lifelong polypharmacy. I don't believe that. I think it's an adjunct to the existing treatment, which include indeed lifestyle and drug therapy. And pathophysiologically, as we know, the pathobiology of hypertension actually has a lot to do with sympathetic overactivation. There's a big role in the sympathetic activation in the blood pressure regulation, because there's a communication between the brain and the kidney through the afferent and efferent renal fibers. And so this communication not only actually affects blood pressure, but also many other disease processes, including the genesis of arrhythmia, heart failure, insulin resistance, insomnia, dementia, atherosclerosis, and so on and so forth. Generally, it's going to be a vicious cycle that is initiated by an increase in sympathetic activity. Patients with atrial fibrillation, sleep apnea, chronic kidney disease have been shown to have a significant increase in the sympathetic effect on different organ and disease processes. And so that's where the idea of renal denervation has come from. Renal denervation basically consists in disrupting the afferent and efferent neural communication between the kidney and the brain. And multiple studies have shown that it's a way that is safe to sustainably reduce blood pressure in patients who have uncontrolled hypertension. These are an example of multiple sham-controlled RCTs that have demonstrated effectiveness of this approach to treating hypertension, that clearly show significant reduction in both systolic 24-hour blood pressure and systolic office blood pressure if you compare interventional treatment with RDN and sham subjects. It's also been shown that RDN provides an always-on effect on 24-hour blood pressure lowering in this spiral hypertension off med pivotal trial. And what I want to show here is that not only reduces blood pressure over 24 hours, but also it does so by affecting the high-risk zone, which is that early morning and nighttime period where there is a significant association between hypertension itself and an increase in the risk of stroke and cardiovascular events. It's a pretty safe procedure. The mean rate of major adverse event is less than 1%. And when it was developed, people feared that it will actually cause significant decline in kidney function. But over the course of time, following up the patients that have received renal denervation therapy, kidney function has been shown to be rather stable and not really impacted by renal denervation therapy per se. This study, which is a patient-level pooled mixed model analysis of the simplistic clinical program, showed that there's durability in reducing blood pressure measurements of up to 18 millimeter of mercury in the office systolic blood pressure over 3 years follow-up. And the highest impact has been shown to be in patients with sympathetic nerve hyperactivation, and such as those that have atrial fibrillation and diabetes. There are at least 2 FDA-approved systems to use in renal denervation. One is simplistic spiral catheter, which we have in the country. Another one is an ultrasound-based system, the Paradise system. And I'll briefly go through each of them. The simplistic spiral catheter is a catheter we actually introduce through the femoral artery, and we identify the renal artery. Then we send the catheter in a branch that should be at least 3 millimeter diameter, and we provide radiofrequency ablation of through the renal artery, but of the renal nerves, which are located just outside in the tissue that surrounds the renal artery. And by doing that, over the course of time, like I showed in controlled trials, it's been shown that there's significant reduction in the blood pressure. The Paradise ultrasound system uses an ultrasonic heating system and a water cooling. The water cooling helps to protect the inner wall of the artery, and the ultrasonic heating system then ablates provides an ablative energy to interrupt the renal nerve signaling across the renal artery. So the population that is going to be most responsive of this strategy are those patients that have either refractory to medical treatment, hypertension with either refractory to medical treatment or with adherence issues. And you have to rule out secondary causes, like we've said. And typically patients with sympathetically driven hypertension are best responders of this type of strategy. If you take a patient who is 42 years old with a blood pressure of 160 over 105 millimeter mercury, who is obese, who have sleep apnea, that patient going to be a better responder of this type of strategy, but that basically consists in blocking the sympathetic overdrive that exists between the kidney and brain, as opposed to a patient who is 85 years of age with a blood pressure of 165 over 65 and whose hypertension is probably mediated by arterial stiffness. And in this particular procedure, you have to make sure that the anatomy is suitable for denervation. And there are a variety of guidelines that we use to select this type of patients. There's also a potential role for people with, hypertension who are expected to have poor compliance to medication, or who experience side effects to antihypertensive drugs. Renal denervation treatment as a therapy gonna have lower incidences of erectile dysfunction, orthostatic hypotension, and acute or chronic renal impairment. In fact, renal denervation therapy has been shown to reduce both micro and macroalbuminuria in people with chronic kidney disease. There are also some other potential indications for renal denervation as a treatment that is based on blocking the sympathetic overstimulation. And these include atrial fibrillation, heart failure, obstructive sleep apnea syndrome, insulin resistance, and so on and so forth. Just to conclude, there are also other sort of new therapies that are coming up. There's a lot of research is going on in the hypertension space right now. And one of them is zilebesiran, which is an RNA interference therapeutic agent. This one inhibits hepatic angiotensinogen synthesis. And as you know, angiotensinogen is a precursor of angiotensin peptides, which have a very pivotal role in the pathogenesis of hypertension. The reason that's why I'm mentioning this is that this drug is actually made as an injection every 6 months. As you can imagine, it may actually help reduce rate of or provide better blood pressure control by avoiding the issues we're facing right now of non-adherence to antihypertensive medicines on a regular basis. So in a study that compared placebo versus zilebesiran administered at different doses, it showed that people in the zilebesiran group had better blood pressure control over placebo. The other study that was recently published is a study of the lorundrostat and its efficacy to control patients with uncontrolled hypertension. This one is an aldosterone synthase inhibitor. Instead of using spironolactone or eplerenone, this treatment just inhibits the enzyme that synthesizes aldosterone. And so by doing that, it's been shown that if it's added to antihypertensive treatment, it provided significant blood pressure reduction of up to 15 millimeter of mercury compared to reduction of 7 millimeter mercury in a placebo group. And indeed, this one might be a good treatment strategy for patients with treatment-resistant hypertension in the long run, but it's still a phase 2 type of study. There is a lot more that needs to be done, but it's just something that is coming up. So just want to conclude and say that hypertension is a real public health challenge. There are many sources of poor control or even resistance. At present, lifestyle modification and medical treatment remain the mainstay of care, but it's important to recognize the role of resistant hypertension clinics that have now established as a referral or as a strategy to help guide and offer consistent care to patients with resistant hypertension, but also renal denervation treatment that has been shown to be both efficacious and safe in multiple clinical trials is coming up and is showing evidence that it helps to reduce the rate of uncontrolled hypertension. And I think it's adding up as a tool in the toolbox that we have to treat and control blood pressure, and it's a welcome development. So I just want to stop here. And before I stop, I want to mention that we've started a resistant hypertension clinic in the hospital. It's located at the main hospital right now, and we accept patients who have uncontrolled hypertension on at least 3 antihypertensive medications. Those that have suspected or that are suspected to have secondary causes of hypertension, and those have failed reaching blood pressure targets due to medication intolerance. You see lots of patients taking amlodipine developing headache or lower limb swelling, and if they take indapamide, they can't sleep. If they take SE inhibitors, they start coughing. All those that you cannot control with standard treatment. And those that are young, less than 40 years, we do accept them and we help them to control their blood pressure in the best way possible. We are a team that is, have, many talents, including physicians and nurses that are specifically trained to deal with this type of situation, and dietitian to reinforce the need for lifestyle interventions. And obviously, many specialties, including nephrology, endocrinology, surgery, to help take care of these patients. So I just want to stop here, Dr. Ngunga and everyone, and welcome any questions to this topic.
Thank you, Dr. Etienne. I really followed up your presentation and kind of giving us the speak from the beginning, how to make the diagnosis all the way up to treatment of the complex hypertension in our hospital. So it's time for question and answers. Hypertension is always a very, very sticky topic. I'm sure we do have some questions from the team here. And Dr. Mohammed is asking, how do you know if hypertension is resistant or just poor compliance? How can you differentiate? That's a very good question. How do you know it's a resistant hypertension or just poor compliance? Because I think we come across this frequently, Dr. Etienne.
Yeah, very, very good question. Indeed, that's a very difficult one, because you have to confirm, you have to rely on the patient, what they tell you, that they take their medications. And just like I said, some patients will tell you that they take their medications, but actually don't. And you will see that if you, for instance, admit them and give them medications on a consistent basis, that their blood pressure will fall into a normal range or even lower ranges. The ideal way would be to do drug levels, but it's not something we do on a regular basis. And even doing it is associated with some challenges. And so all in all, you just have to rely on what the patient tells you, and you have to do ABPM to confirm if their blood pressure is under target or if it's not.
Very good, Dr. Etienne. The slide you showed very nicely how to evaluate your patient whom you are suspecting hyperaldosteronism. And Mohammed wants to see it. Can you just go through that? How do you assess your patient whom you are suspecting hyperaldosteronism? Because it keeps cropping up as the commonest cause of so-called difficult to control blood pressure, especially in young people. It keeps cropping up at
Definitely, I will do that. I think this is the one, yeah?
Yes, yeah, and they're very good just to show the algorithm of how to diagnose this. Maybe you can go through it.
Yeah, so primary aldosteronism, like I said, is much, much common than previously thought. It's estimated that about 10 to 40% of hypertensive patients, particularly those with difficult to control hypertension, will have some form of primary aldosteronism. And so it's important to make this diagnosis and to provide accurate and adequate treatment for this type of situation. And so what we normally do, well, the simplest thing is to refer this patient to the clinic that deals with this kind of problem on a day-to-day basis if you believe that there could be reasons to suspect primary aldosteronism. But the clue to the diagnosis is you have high blood pressure in a person and who is adult or young, and it's relatively difficult to control. But on top of that, you have lowish to low potassium. We recently had a patient admitted to HDU with hypertension. She came in with a blood pressure, I think 200 and something, over 100 and something. And she had hypokalemia of 2.6. And she hadn't been taking any diuretic medications for a long time. And that was a clue when we saw this. And she had some, muscle pains, which I suspected was maybe symptoms of hypokalemia. So when we saw that patient, we collected blood samples for aldosterone and renin activity. And we saw that her aldosterone to renin ratio was actually very high at around 60. Anything that is above 20, provided aldosterone levels are more than 15 nanogram per liter, is quite significant. And when you see this, you have to do a saline infusion, because sometimes you have to administer saline or sodium to see if it can suppress aldosterone. If aldosterone cannot be suppressed by this method, and the saline infusion test administration is actually pretty simple. We do it in a cath lab here every now and then, and it consists with basically giving 0.9% saline infusion over a 4-hour period when the patient is seated or lying on his bed comfortably. And what we do in the test, we collect blood samples before the test to assess aldosterone and renin, and we collect at the end of the test as well. And we compare those two measurements of aldosterone. If saline infusion has helped to suppress aldosterone, then we confirm this is probably not primary aldosteronism. But if it does not suppress, then we know that there is somewhere too much aldosterone being secreted in the system. And the following step then consists in imaging of the adrenal glands, and CT scan is the go-to test. But if the reasons as to why CT cannot be performed, or the patient has contrast allergy or that kind of situation, then you can do MRI, which then would show if there's a mass adenoma, hyperplasia, or that kind of situation. And if there is, it still does not or would not indicate that that same mass is the reason for aldosterone hypersecretion. So you still have to do adrenal venous sampling, which then would indicate if there's too much aldosterone, because you do it on both, adrenal veins. And usually if there's one adenoma in one, or many adenomas in one adrenal gland, and you do see from that venous sample that you've taken from the adrenal vein, there is too much aldosterone compared to the other side, then you do confirm that there is unilateral adenoma or hyperplasia that is secreting too much aldosterone. And so the treatment strategy in this situation, particularly if the patient is young and able to undergo surgery, would be an adrenalectomy or adenectomy to just remove that mass. But if you're dealing with a situation where there's bilateral hypersecretion of aldosterone, or a situation where the person is too old, cannot undergo surgery, then spironolactone, which is an aldosterone antagonist, is just pretty good.
Okay, thank you. Thank you, Dr. Etienne. There's somebody who is asking if they have a patient in the village who, not the village, but maybe in a remote town such as Garissa, Kajiado, and they want to treat the patient pending decision to renal innervation. What are the treatment options for that patient? BP is 150 or 100 despite 4 drugs, including a diuretic. What should they do?
No, I think the treatment strategy remains the same. Consistent lifestyle interventions, which basically weight loss if the patient is overweight or obese, sodium intake reduction, maybe more potassium intake, sleep, diet, all that, plus treatment. And generally, treatment gonna consist in at least 3 types of medication in a single pill combination. Generally, a CCB, an ARB, or ACE inhibitor, and a diuretic, usually a thiazide-like diuretic. And if those three cannot help reduce, or control blood pressure, then you can add spironolactone, or you can consider referral to a center that can perform renal denervation therapy. Spironolactone has been shown in many studies that it can help, and some of the reasons as to why it actually good medication is that some of these patients have primary aldosteronism that has not been diagnosed, and by giving them an aldosterone antagonist, you actually treat that by suppressing the hypersecretion of aldosterone.
Okay, thank you for that, Dr. Etienne. And now questions about renal denervation therapy. Is it a one-off therapy or is it a therapy that you have to keep repeating every so frequently?
It should be a one-off. It should be a one-off treatment. And we do it on both renal arteries. And we can perform multiple ablation therapies in a single procedure, but it should be one single procedure. The safety profile of it, like I presented, is pretty low. It's less than 1% risk of complications. And the major complications that have been seen are related to access site complications, including bleeding from the femoral access site, but not really from getting into the renal artery and causing damage to the nephrons or to the artery itself. There are very, very few cases in the literature that have been reported of, for instance, renal artery stenosis as a result of renal artery denervation.
Thank you, Dr. Etienne. What are the complications of some of these renal denervation? Do you have any complications?
Like I just said, the complications are primarily based on vascular access complications. They include bleeding, pseudoaneurysm, AV fistula, and these are rare. Standard complications for, catheter-based procedures, basically, and which are less than 1% in occurrences. But specifically for the renal denervation, once you get into the renal artery, then there's a risk of kidney anatomy damage. There's a risk of contrast allergy or contrast associated nephropathy if you give too much contrast during the procedure. And those are basically the things that you would worry about. And there's a risk of renal artery stenosis. There would also be a risk of for most patients, and I will tell you, most patients who undergo this type of procedure do get a lot of pain because you basically are ablating nerves that are pretty sensitive, and they tend to have lots of pain. So we tend to give lots of sedation and lots of pain medications. And if you give too much for a specific individual, then they may require intubation and that kind of thing. So you would call that a complication as well if it ever happened. But the risk of it is less than 1%. Dr. Ngunga, are you still there?
Oh yeah, hi. Yeah, so thank you for that, Dr. Etienne. And I think I don't see any more questions in the group here now. So I'm happy to end this session. It has really been very enlightening about the treatment options for patients with hypertension. So we don't have any more questions, I think the team can get CPD points once they register on the link which is given there. Please register and you get your CPD points from the Kenya Medical and the Dentist Board. So please register for your CPD points. So once again, thank you, Dr. Etienne, and we'll see you soon in the resistant hypertension clinic. Bye-bye and have a good evening, afternoon.
Yeah, thank you. Thank you for your attendance, everyone. And again, just a reminder that we run a resistant hypertension clinic. If you do have these patients with difficult to control hypertension, don't fail to refer them to our clinic. We'll be happy to take care of them.